So in terms of partial breast treatment, just be aware at Astro APBI suitability criteria. Note that the ABS and Get Gastro guidelines also exist. Astro suitable are patients that are at least 50 years old. They're T1 tumors, meaning less than or equal to 2 centimeters in size. They're ER positive. It's invasive ductal with at least 2 millimeter margins, or screen detected and low to intermediate grade with at least 2.5 centimeters. Um, at the most 2.5 centimeters DCIS with at least 3 millimeter margins. So again, note that everything can be larger with DCIS. The actual focus of DCIS itself can be up to 2.5 centimeters as opposed to 2 centimeters for invasive ductal, but you need 3 millimeter margins for DCIS as opposed to just 2 millimeters for invasive ductal. So one more time, the suitable criteria for APPI: age at least 50, a T1 tumor meaning less than or equal to 2 centimeters, ER positive, invasive ductal with at least 2 millimeter margins or screen detected, and low to intermediate grade, less than or equal to 2.5 DCIS with at least 3 millimeters. SIM, CT after device placement on all patients to determine conformance. Typical balloon diameter, if you're going to do Mammocyte, is 4 to 5 centimeters and a final fill volume of 35 to 70 milliliters. The trapped air fluid should be less than 10% of the PTV eval volume. The minimum balloon to skin distance of 5 millimeters is required. Ideally, it's 7 millimeters. The dose for partial breast EBRT is 3.85 times 10 BID with 6 hours in between. GTV is the cavity. CTV is the GTV plus 1.5 centimeters, but cropped 5 millimeters from the skin and cropped from the posterior breast tissue, i.e. the pec muscles and the chest wall are excluded. The PTV is the CTV plus 1 centimeter. PTV eval crops 5 millimeters from the skin and excludes from the part beyond the posterior extent of the breast tissue, like the chest wall, pec, and the lung. You treat 3D conformal, field and field is okay, 3 to 5 field non-coplanar beams. No beam can be directed towards critical structures like the heart, lung, or contralateral breast. Brachytherapy is 3.4 gray times 10 BID. Treatment starts within 9 weeks following lumpectomy. Prescribed to 1 centimeter from the surface of the balloon. CTV equals PTV equals 1 centimeter expansion from the balloon minus the balloon. PTE eval equals PTV crop 5 millimeters from the skin, also exclude from the muscle and chest wall. Using iridium 192 HDR separated by at least 6 hours. X-ray prior to each fraction to assure no change in balloon diameter or device orientation. With brachytherapy, any trapped air fluid in the cavity must be less than 10% of the volume of the PTV eval. Also, you must have at least 5 millimeters balloon to skin distance, ideally greater than 7 millimeters actually. In terms of Mammocyte APBI, which is RTOG 0413, skin chest wall max dose should be 145%, ideally less than 125%. Coverage V150, meaning the volume getting 150%, is less than 50 cc's. V200 less than 10 cc's. Dose homogeneity index is greater than 0.75. You want greater than or equal to 90% of the PTV eval, getting greater than or equal to 90% of the dose. PTE eval equals balloon plus 1 centimeter, crop 5 millimeters from the skin and at the pec. If you're doing external beam, APBI per RTOG 0413, PTV eval greater than or equal to 90% of the PTV eval gets greater than or equal to 90% of the prescription dose. The uninvolved ipsilateral breast, less than 35%, receives 100% of the prescription, less than 60% receives 60% of the prescription. Contralateral breast, less than 3% of the prescription at any point. Ipsilateral lung, less than 50% lung receives less than or equal to 30% of prescription. Contralateral lung, less than 50%. 15% of the lung receives less than or equal to 5% of the prescription. Heart, for right breast, less than 5% receives less than 5% of prescription. Heart left breast target, less than 40% receives less than or equal to 5% of prescription. Max dose, less than 120%. Thyroid Dmax is less than or equal to 3% of the prescription. KV every treatment aligned to clips. Electrons 20 gray to the surface minus 1 millimeter. In terms of the studies, UK import low, hypofrac, 40 gray and 15 fractions versus reduced dose whole breast plus a partial SIB, 36 gray plus 40 gray and 15 fractions versus partial breast irradiation, 40 gray and 15 fractions. There was no boost on this trial. There was non-inferior local control at 5 years. Slightly less breast hardness with partial breast equals similar to improved cosmesis with APBI. Bottom line is whole breast plus partial breast SIB and external beam partial breast are non-inferior. bed plus 1.5 centimeters to CTV, then 1 centimeters to PTV treated with tangents. In contrast, the RAPID trial showed worse cosmesis and late toxicity with partial breast, which was treated 38 gray in 10 fractions BID, compared to whole breast, which was either 50 and 25 or 42.56 and 16. The same 8-year ipsilateral breast tumor recurrence was found approximately 3% non-inferior. So external beam partial breast is non-inferior to whole breast in local control. However, late skin toxicity is worse with external beam partial breast. Authors propose investigation of other regimens. GAC-Gastro was 50 and 25 whole breast versus interstitial multicatheter brachy, either high dose rate or pulse dose rate, 32 gray and 8 fractions or 30.3 and 7 fractions BID. These are favorable patients, grade 1 to 2, small size. There was no difference in ipsilateral breast tumor recurrence or disease-free survival. Interstitial APBI and whole breast are non-inferior. Toxicity and cosmetic outcomes are not different. RTOG 0413 and SABP B39. Stage 0 to 2 breast cancer less than 3 centimeters, no more than 3 lymph nodes positive, either got whole breast 50 and 25 or 50.4 with an optional boost. 34 gray and 10 fractions BID brachy with multicatheter intracavitary, or 38.5 and 10 fractions BID with 3D chemo RT. Need to recall here that brachy APBI was lower at 34 gray BID, while 3D conformal radiation was 38.5 gray. The 10-year ipsilateral breast tumor was not equivalent. It was 4.6 in the partial breast versus 3.9 in whole breast. So partial breast with EBRT or mammocyte did not meet criteria for equivalence to whole breast in RTOG 0413. This is the only trial like this. Partial breast had slightly worse grade 3 toxicity. Cosmetic outcomes were not different on patient or MD rated assessments. Florence is 30 in 5 partial every other day. Almost all partial breast studies show that partial breast is non-inferior or equivalent except RTOG 0413. There are mixed results with EBRT partial breast. RAPID studies showed worse cosmesis with EBRT, PBI, and 10 fractions BID in RTOG 0413. And SABP B39, partial breast EBRT and catheters showed small increase in toxicity. The Christie study also did not show non-inferiority. UK import low showed less toxicity with APPI, EBRT, and 15 fractions daily. Target showed IORT is non-inferior to whole breast in the pre-pathology group and less non-cancer death rates. A meta-analysis shows no difference in breast cancer mortality between PBI and whole breast. There's actually a worsening of overall survival with whole breast. The reasons why are debated.